All right, I think we're ready to go. Good afternoon, everyone, and welcome to our fourth town hall judicial branch meeting. It includes employees of the judicial branch and some of our judicial partners. It's been great hosting these meetings. I think they've been important and helpful to supply some information to everyone. Today, we're going to focus on vaccines and the state of COVID in Delaware. Before we get going, I wanted to introduce some people. Gail Lafferty is here off screen. She's the state court administrator. And with me, like the other town halls, is Dr. Alfred Bacon, who's an infectious disease physician here in Delaware. We're really privileged to have Dr. Bacon advising the judiciary on our reopening plans. I think if you go back and you look at our presentations, you'll see that he's been pretty much spot on his advice and how Delaware has been dealing with the pandemic and what the future holds. So we're really privileged to have him once again appear with us. Just so everyone is focused on what the path forward looks like for the court system, we are going to move to phase 3 of the court's reopening plan starting on June 1. I would caution everyone that we are not in phase 3 right now. We're going to take our time and see how vaccination uptake is working in Delaware, making sure that we're prepared to enter a busier phase, including jury trials on June 1. But I anticipate, unless things really change for the worse, that come June 1, we will have more employees back in judicial facilities and we will be fully engaged in going into phase 3 of the court's reopening plan. So without any further delay, I'm going to turn the program over to Dr. Bacon, who's going to do his usual good work educating us on where we are with COVID and vaccines in Delaware. Dr. Bacon?
Chief Justice, thank you for that introduction. And it's a pleasure to be here again with you. It's been quite a year, and I reflect on the fact that it was almost a year ago we had our first discussion. And I think the mode at that point was, quote, run for the hills, quote, protect your family, your colleagues, your friends, and your employees, and et cetera. I think the current mode for today is time to come back down to the village, do so cautiously, carefully, not too fast, particularly with the variant discussion. And I think that it's a well-timed discussion for moving back to some degree of normalcy with the timing of your phase 3, which I think is very appropriate, but also cautiously. Today, I'd like to cover the epidemiology, where we sit now in Delaware with the virus. I think the topic I want to move to and go through a lot of discussion with will be the variant prevalence in Delaware, nationwide, and also how the variant will affect vaccination, which is, I think, on everyone's mind. I want to talk about vaccine administration, where it sits, and then get into a discussion at least on hesitancy for vaccination, vaccine safety, and then a really good, I think, review of DPH's and Delaware Public Health guidelines for after you're vaccinated, what can you and can you not do? So you have a sense that certainly being vaccinated is not a release from total control, so to speak. Daily trends nationwide, you've seen this curve so many times. Early on, this is over a year ago, January 22nd of 2020, moving through the various peaks and troughs associated with shutdowns, opening up, shutdowns, and then subsequently the fall, which frankly, in my arena, the month of November, December were quite rigorous, frankly. And so this feels like a wonderful improvement, but if you'll notice, the current status as of April 5th with numbers nationwide are surprisingly similar to where they were June a year ago in terms of new cases. The area of hotbed in the United States is the Midwest, upper Midwest, Wisconsin, Ohio, Michigan, where it's being driven by younger populations and less restrictive behavior. And that's, I think, an important point, as well as Wisconsin and Michigan are leading the way with the B117 variant, which is highly contagious, more highly contagious, and spreads quite readily. We'll talk about that later. This is Delaware's curve over time. It mimics the nationwide trend. As you can see, we've come down, but we've plateaued here. My experience over the last 1 month in the acute care facilities is we have a constant level of virus present, admissions present. I will also tell you that what we're seeing acutely over the last 3 months is a far younger population. And when they come in, they're very sick. So this virus is now, as you'd expect after vaccinating the older population, moving through the younger populations as well.
And what do you mean, Dr. Bacon, by younger populations?
Under 50. I'm seeing a lot of under 50-year-olds. We admitted an ICU patient to be intubated who's 47 today. We have a 37-year-old waiting to be intubated, a 27-year-old in the ED waiting to come upstairs, and I lost a 50-year-old 2 weeks ago. So it's not the 65 and over population that is certainly at high risk, but they have their behavior patterns, all due respect, are probably a little more conservative, a little less interactive for a number of reasons, by choice or just that's the way it is sometimes. So the Delaware dashboard, which you can see every day on the DPH website, reflects 314 new cases every day, 68,000 new cases nationwide every day. Current hospitalizations right on, and we're still running on 5%, 5.5% positivity rate on daily testing, which means that's easily the prevalence in the population. My guess is it's twice that because there's a large asymptomatic population that doesn't get tested very often or want to get tested or need to get tested. I think the exciting thing here is there have been over 560,000 vaccines administered in the state of Delaware. There are 1 million humans in the state of Delaware, and certainly some of these are out-of-staters that work in Delaware, but this is, I think, fantastic. And my colleagues and I are thrilled to see this. And I think we've had 190,000 fully vaccinated, getting the 2-dose Moderna, Pfizer, or the single-dose J&J, which we'll talk about in a minute. I think this speaks to really a positive summer. And I said summer. I didn't say positive May. I didn't say fantastic June. Summer. Deaths remain in the higher age populations, as you can see. But once again, these are Delaware deaths creeping down into this group. It's this group here, age 17 to 50, that are certainly sharing this virus in the community, and they're passing it on to each other, of course, but also on to the older population. So routinely, I see an older individual now, I'm hearing that, oh, yeah, I know I got this virus from my nephew's son or my uncle who happened to come by out of the blue to say hello to me because things were going well. And then I got a phone call 2 days later, they had COVID, and now I'm in the hospital sick. Once again, percent positivity running around 5.5%. Love to see that go down to 2 to 3% range, which it will. I just don't know when I can tell you that will happen. This is great data that Sean O'Sullivan put together from DPH, looking at venues where the disease is acquired. 25% continue to be acquired in restaurants and bars. Most bars are now serving food, so they're called restaurants. We've had that conversation. Recreation centers, gyms are a hot spot. Once again, religious services where singing and choir practice is active and they're not distancing remains a setting for acquisition. But you can certainly see these are areas where everyone should be cautious when they travel to a hair and nail salon. Most salons should have appropriate behavior for distancing and mask wearing and shields. Large gatherings, gyms, which have opened up again, certainly are an area of concern. I think restaurants are at 60% capacity right now. There's nothing new in the treatment arena. Frankly, we are using a lot of outpatient monoclonal antibody. That's the Regeneron cocktail. Someone who's positive for the virus, who know they've acquired the virus from another person. They're now using this monoclonal antibody infusion to prevent disease and therefore prevent admission. It's very successful. In fact, there's now a push to use these monoclonal antibodies in people that are just exposed to the virus, not those that have documented disease. It's really an impressive infusion. You have antibodies given to humans to prevent acquisition of disease, much like the convalescent plasma that we used early on in disease. That's fallen by the wayside, but still is efficacious early on. Inpatient-wise, steroids, we know lower mortality by 30%. IL-6 blockers are immune modulators. They lower mortality by 10%. Remdesivir, maybe 3 to 4%. We haven't seen a lot of variants develop that are resistant to remdesivir. That's probably because remdesivir is not widely used, and probably because remdesivir is not an effective agent, so it doesn't push the virus to do things genetically different. One thing we'll talk about is anticoagulation. This disease is a hypercoagulable state, and that means that people with this disease clot their blood more readily than other people. So we're seeing a lot of individuals late in disease coming in the hospital with blood clots in the leg and blood clots in the lung and abnormal clotting parameters, suggesting that the immune system turned on by the virus is probably turning on your coagulation cascade and making your blood clot more easily. I will tell you, I think that plays into the current J&J and AstraZeneca vaccine issues of seeing people having blood clots after being immunized. That's not documented. That's just my own read on that situation. And post-discharge, we're seeing a lot of individuals coming back with just horrendous pulmonary function, fibrotic lungs, lungs that don't function well, with no predisposing lung disease beforehand, and they're being followed long-term by my pulmonary colleagues, and they're improving with steroid use over a long time. And then we're also using a lot of anticoagulation in the post-discharge population. So what is it with these variants? What do we need to know about variants? Variants are a naturally occurring genetic mutation event that occurs in any virus that genetically is active. So there are 68,000 new human infections with COVID daily in the United States. Every one of those 68,000 people has 1 million viral particles replicating constantly. So among all those replicating viruses, genetic mutations occur. Now, these mutations can be beneficial to the virus, as in the B117, the 135, the South African, the Brazilian variant. They allow that virus to propagate more easily. But many of these mutations are detrimental to the virus. They don't allow it to exist anymore. They can't form their envelope protein. The spike protein doesn't form properly. So they often fall by the wayside with the detrimentals. I'm actually amazed we're not seeing more variants, frankly, and that's something to talk about. The B117 must be very hardy, very aggressive. It's taking over the playing field, basically. These variants allow increased affinity for ACE receptors. Those are the ways the virus binds to the human's trachea and cells. They increase the viral load. So you'll have a lot more virus in your trachea because it's more genetically able to do that. And therefore, when you cough on someone, you're spreading more virus per cc of air. We have more viral particles per airway and therefore more highly contagious. And this probably increases the inflammatory response and leads to the poorer outcomes and higher morbidity in the variants of interest and actually the variants of concern, which we'll talk about. CDC classifies variants as those of interest, means, hey, this is a new virus. Let's keep an eye on it. Does it have a mutation that affects us? Variants of concern, which are variants that have increased virulence, means more actively spread, that are higher morbidity and mortality related to this, and those that evade any immune response from the vaccines. We're going to talk about these various different organisms. The B117 first seen in UK, 135, one seen in South Africa, the Brazilian variant, which is really a difficult organism, and then the California variant still under discussion. This doesn't mean, although it is true that someone from the UK brought this here, it doesn't mean that this is the same virus from person to person. It's just that the 117 categorizes that variant that can pop up randomly anywhere. The CDC also looks at variants of consequence. That means variants that are now organisms that are completely resistant to all of our countermeasures. We've yet to see that occur. which is good news, which means act now. We need to work now to vaccinate individuals to prevent that from occurring. In Delaware, as of April 9, this is the variant status. The B117 is a predominant variant in Delaware. If you look at the variants as a percentage of total cases reported, it looks like around 9% based on the April 9 data. I don't think that's true. I think we have a lot more variants here than we know. But keep in mind from this slide, the B117 UK variant is the predominant overwhelming variant we're seeing in Delaware. That's an important point. One South African, there may have been a Brazil, but I'm not aware of that. They've not reported that on their website. If you can see this slide, it's a little lower than I wanted size-wise, but this looks at Pennsylvania, estimated share of cases that are B117 in Pennsylvania. From February, pretty close to 0, in 2 months, it's now 50% of the virus spread in Pennsylvania is B117. And as a percentage of cases reported, it's up to 50%. I suspect we're close to that because we're close to Pennsylvania. These bugs don't know state lines, of course. This is, as many of you heard last time I spoke, my favorite slide. If you become vaccinated, this is the 2-dose Pfizer, I believe, vaccination trial, looking at placebo, the red line, those that did not get vaccinated, versus the blue line, those that did get vaccinated over time, those that developed COVID. Well, as you know, once you become vaccinated and after you have your second vaccine, the second vaccine 3 or 4 weeks later is the time when you are going to become fully vaccinated, and 2 weeks after that point. So really from day 0, it takes out to day 42 to be fully safely vaccinated with the Moderna, for example. But you see benefits early on, which is, I think a positive thing, but you still see disease. So individuals, like there's all in the news discussion of, oh, there's breakthrough, 3 out of 700,000 vaccinated people in Seattle became sick and were hospitalized. That's going to happen. A vaccine that is 90% efficacious is going to have 5% of the people become sick, hopefully not as sick as others. I've also seen a lot of patients admitted now that are getting sick down in the 0 to 14 day stage. So they've had their first dose of vaccine, have not had their second dose of vaccine, and they're getting sick. This makes 2 things pertinent. Number 1, do not lose or drop your guard. You will still be at risk all through this time frame. Getting 1 dose does not totally protect you. You must remain vigilant. And the fact that you have disease out here also says the same thing. Certainly, if you've been vaccinated, you're in a much better place to mitigate your own risk and the risk to the people near you. So you're protecting a whole pod of people, but you still are at risk for getting sick. And there's never a 0 risk. Delaware's current vaccine status as of April 6th, we've now moved to everyone 16 and up. This is really very good news. And the data does show, and DPH has commented, that even though the J&J vaccine is on hold, the supply of Moderna and Pfizer is excellent. And frankly, I think that they're going to obviously have much more population-based acceptance. And I think that that will continue vaccination at a strong rate to protect the population. We have to protect those age 18 to 50 so we can protect all those individuals, but also their grandparents, their uncles, their aunt, their parents, the group that are still at risk in that 5% group. Obviously, cumulative doses. Because I'm a healthcare worker, my first dose was back in December. My wife's first dose was way down here, but it was along with the general population. Both my children, age 37, have now been dosed. They're in New York and one's local. And I was thrilled to get vaccinated, but I was more thrilled to have my spouse get vaccinated because she was protected and she could go back to somewhat of a more normal existence. And my kids were thrilled to get vaccinated, partly because they could spend more time with me, but also they could spend more time with their colleagues in a safe manner, still being protected, distancing, wearing masks. And also they felt they were protecting people they weren't even related to that they'd come in contact with in their work and in their play. Vaccine status age, based on age in the state of Delaware, percentage of people fully vaccinated, 19% of the whole state population fully vaccinated, 65% of those 65 and over fully vaccinated, 82% have received 1 dose, 65 and over, and 35%. This is really good. We get down into the 70% range. I think most experts will tell you that for this virus, Herd immunity at 70% is the goal. We need that herd immunity in the young population. That's something they need to come to terms with, and they need to be comfortable with it. I mean, they're young, and there's certainly issues related to future issues with the virus, et cetera. I'm not gonna tell people not to be cautious or be thoughtful. I think that's a thoughtful view of this is not inappropriate. But
Doctor, on this slide, if you look at that percentage, although it's a great number that 65% in the 65 plus age group have been fully vaccinated, 35% have not. And
yes,
as you have been telling us, this is the reason why the younger population really needs to get vaccinated, because they are the greatest risk for this older population. Isn't that right?
I agree, and that's a really good read on the discussion. I would also say that of these 65%, the majority are likely extended care facility residents, those that are employed, those that have access. I think access to vaccination is really important, and that's something to really work on as well. But that's a really good point to bring up. This just says the same thing. I mean, obviously, fully vaccinated percentage by age group in Delaware. So what about the variance in vaccine? So this was from my February discussion, I believe, where the Janssen, which is the J&J vaccine, single dose, still had good efficacy or strength against the South African variant. Novavax was the same way. AZ actually has some good activity versus South African and the UK variant. Moderna, Pfizer, one of the things which has clearly come out the last few months is both Moderna and Pfizer are very tuned into the fact that they can change the mRNA in their vaccine technique very readily. And so I think what we're going to see over time is a series of vaccines. For example, now the B117 is a predominant vaccine with its altered spike activity. We'll find the mRNA for that new spike gene probably included in the Moderna Pfizer vaccination system. As we, like influenza, every year they look at the influenza predominant strains and identify, sometimes inadequately, the predominant strain to vaccinate us against annually. We'll probably see that occur. It does remain a race, vaccine versus variant. I think that's very important. And I'm going to share my thoughts on that in a second, probably. This is a look at the NIH's view of variants. Down here listed the B117, South African, Brazil, New York variants. These are, I think, of interest right now, not concern. California is of concern. Looking at how these vaccines stack up against, how these variants stack up against the vaccine. This data is based on test tube studies, taking the blood from people vaccinated and seeing if they are active against that specific variant. As I'm a positive person and like to have positive spin here, and our glass is always half full, the B117, which is now the predominant virus in the United States, has only minimal ability to evade the vaccine. That speaks to the fact that this current vaccine we're using, all the current vaccines, remain active against the B117 and is probably, of all the variants you're going to look at, this is the one you want to have an opportunity to act against. Therefore, now the B117 is out there, this is the time to get the vaccine pool up, get the people vaccinated up where they should be, so we can avoid moving into the Brazil variant, for example, or the California variants, for example. So let's act now so the predominant vaccine, the predominant variant is stamped down before these variants have an opportunity. Now that doesn't mean that's going to happen, but that's, we have to try and do that. So what keeps me or what keeps others from jumping into vaccination? I think that there's a certain appropriate degree of healthy skepticism I think all normal humans have. I'm skeptical. I don't do new things quickly. And that includes antibiotics, that includes interventions. You like to have some evidence to support, number one, the efficacy. Does this work? Well, now we know this works. Is it safe? Well, I think the safety issues are not minor and they should always be kept in play. And then the other question that keeps some people being vaccinated, well, do I really need it? Am I at high risk? Everyone is at high risk. You go to the gym, you're high risk. You go to the grocery store, you're at potentially high risk now. Now the B117's out there, more virus in the air. I think the risks are increasing for simple contacts. And then costs. So I think these are all important issues. How do you deal with these? Well, number one, I think all of us need to look at the data on side effects and perhaps make a decision of where they're acceptable or not acceptable. I have close friends who have immune-mediated diseases. We spend a lot of time talking about, well, I'm sorry, but you have immune issues. Perhaps you're not the right candidate. Just now, let's see how it rolls out the next few weeks. And most of those individuals have viewed the data and frankly, they need to get it because you're immune compromised. And I'm glad they were able to come around. But you need to be comfortable with someone managing your health. That speaks to the fact that if your healthcare provider said it's safe, I'd like to think you have confidence in your healthcare provider to listen to that. So you should all, anyone who's listening to this, should all talk to your healthcare providers, and hopefully they'll give you the proper information. Also, there's no significant cost at this point in time, and it's time to get back to work and school safely. And those are all appropriate ways to look at it. There have been 168 million doses of vaccination, all vaccines given throughout the United States as of April 5th. Well, I know on Saturday, April 10th or so, there were 4 million doses given that day alone. So this number is rising rapidly. This gives us an excellent opportunity to look at side effects, and the CDC has some excellent techniques in place for that. They're felt to be safe and effective, and we'll talk about that. These are the typical side effects: swelling, a lot of pain. My arm still hurts, frankly. I shouldn't say that for my vaccine that I got in January, but I look upon that with fondness. I'm pleased that it still hurts. Local pain, fever, headache. Headache's very common. Tired, fatigued. Fatigue really hits a lot of people about day 2 to day 5 after vaccination. Muscle pain, chills. To be honest with you, many of us would say you want to have some reaction to this vaccine. That sounds perhaps inappropriate, but you want to make sure your body knows it's there and it's reacting to it. I do think that these reactions tell us that your immune system's turned on, doing what it should be doing, and will protect you in the future.
Doctor, why does your arm hurt?
I don't know. I think it hurts because you've had a shot. And if you think about the way the Moderna and Pfizer are constructed, the mRNA gets injected into the smooth muscle right in your arm. And that's where the action is. And so your arm is turned on. Your arm becomes the machine creating the viral particles to react to. So that local site is probably part of that issue. Plus, getting a shot can be painful. The flu shot hurts. All these shots hurt. The shingle shot really hurt. Those people that gotten the shingle shot, that was pretty painful. I think this shot was less painful than the shingle shot, but that's a personal experience. But that's my thinking. I can tell you how safe this vaccine is. I can show you the data. Only up to 9% of people have some low-grade chills, fevers. 2% have a little fatigue. But I don't think that hearing from me necessarily will allow you to collect the information yourself. On the DPH website, these are examples of individuals in Delaware who are willing to post for their friends and community and those of interest to read what their experiences have been. And when we're finished up in a minute I think there's a good video that goes through some of your colleagues that you're working with who've gone through the vaccination process. This is Sean O'Sullivan of the judicial system. This is one of your vaccine clinic sites administering vaccine, and this is Chief Justice Seitz getting his vaccine. Just to demonstrate, there's a lot of smiles under those masks, I'm sure. So number one, over 170 million have received this vaccine. Number two, anaphylaxis, which is sudden airway dysfunction. I can't breathe, I'm having a hives reaction. Anaphylaxis, which is potentially life-threatening, occurs at a rate of 2 to 5% per million. So in the United States, there have been no more than 800 events of anaphylaxis, none of which have died, by the way. So there have been no deaths related to vaccination. And I feel really comfortable saying that. Even in the recent J&J data.
There's a recognized treatment for anaphylaxis too, right?
Sorry, repeat that?
There's an immediate treatment for anaphylaxis too, right? You get
Every site has the equipment on hand, which is typically epinephrine, as well as antihistamine infusion and fluids. So the answer is yes, that's always right there. The vaccine is now clearly safe in pregnancy. It's safe for those that are immune compromised, those with underlying disease like lupus, malignancy, cancers. And there's a really interesting app going on that can be used, that CDC uses, called the Vaccine Adverse Event Reporting System, which those of you that have gotten vaccinated are aware that you probably get a text every week saying, how you doing? And that's a wonderful system. This vaccine is being watched closer than I think my perception is, and than any other rollout of new intervention that I've seen. Now, I think that's appropriate because these vaccines came along faster than any other rollout I've ever seen. So it's the rapid ramp up, I think, deserves rapid, acute, microscopic, granular view of events. And I think it's really receiving that. And it's showing excellent transparency and really good results.
Doctor, how about children?
Well, there are studies now going on with 16 and unders with the vaccine systems, and I think they'll be clearly showing safety. It's rare to see a lot of studies in kids. We don't do a lot of research in kids because they're really a legally difficult population to deal with, and requires a lot of other paperwork. But I think we'll see that in kids it works quite well.
What do you think about the timeline for authorization for under 16? We know that I believe Pfizer is authorized for 16 and over, and Moderna is 18 and over, if I've got that right. But what about under 16? Do you have any idea what the timeline might be for approval?
I do not know the answer to that. My projection would be that once the vaccines have been in arms for 3 months, which would be June or July timeframe, we'll have a wonderful timeline suggesting by September, i.e. school time, for all that to be a go. I guarantee you, if it's safe in children, every college, university, school will come close to requiring it. And I think they're legally allowed to require it for those purposes.
Doctor, there's a question in the chat that there have been rumors that the vaccine may affect a person's fertility in the future. And is there any medical basis for that?
No, I'm not aware of any data to support that comment. And it's even been discussed at meetings among my colleagues. None of us are aware of any of that discussion, or that's the case. I do want to focus a little bit on the AZ vaccine clotting disorder that was reported. This is a paper that came out February 9th, which was last week, in the New England Journal, looking at the reported cases of rare blood clotting disorders in those that received the AZ vaccine in Europe. 80 million doses of the AZ vaccine were given in Europe. Of those 80 million doses, there were 11 patients in Germany and Austria that had clotting disorders: abdominal clotting, lung clotting, and brain clotting. The brain clotting we're seeing with the J&J. These were women predominantly aged 22 to 49, occurred 5 to 16 days after vaccination. Of those 11, there were 6 deaths. So this put the AZ vaccine on hold in Europe, and it's actually being reopened, I believe. The data shows this is an unusual clotting disorder that is immune mediated. It's immune thrombocytosis and thrombosis, which means you clot. And when you clot, your platelets go down. So it's probably immune-driven clotting. And I don't know what it will finally turn out to be caused by, and how, or if it will be truly linked to the vaccine. Because 80 million doses, 11 patients is certainly 1 out of 8 million. Trying to do the math rapidly. The Janssen vaccine, the J&J vaccine, as of this week, 6 patients, age 18 to 48 women, reported were reported as having what's called cerebral venous thrombosis, another clotting issue in the brain. There have been 6.8 million doses of the J&J vaccine given, which means we're talking about 1 event per million doses. At the risk of, I wouldn't want to be that one person, and believe me, I don't want to belittle that discussion, but 1 out of a million is extremely rare event with any medication, frankly. And vaccine of this nature, the joint CDC FDA group, the advisory committee for immunization practices met yesterday, and they've chosen to keep the J&J vaccine on hold nationally. My perception will be that'll be about a 2-week hold, because if this is a pertinent issue, a lot more cases will fall in because people go, oh, yeah, I had a patient with that issue, and you'll find more reports. And that'll be a time frame to see how serious this issue will become. I don't have an answer for that. No deaths in those people as well. This is pure conjecture, this slide. I think both of these vaccines are adenovirus vector vaccines, means the DNA, there's a DNA segment put into an adenovirus and then injected into a human. So they both have a similar scientific technique. This is the more tried and true historical vaccine technique compared to the Moderna and Pfizer. COVID-19 has a lot of clotting issues associated with it. I think it turns on immune thrombosis, and that's one of the reasons we see so much clotting in our patients. So as the vaccine turns on your immune system, it may be triggering an immune-mediated thrombosis in this population. These are very rare events, and this disease exists in the population in general, waiting for a trigger to happen. So this may be the trigger for some of these people that have this process. So it's 1 to 2 per 1 to 10 million. I mean, that's rare, but I don't want to be that one. But those are, it's all risk benefit. Are there patients predisposed to this? I think that'll be the answer we'll learn about at some point in time, but I don't really know. But I think we'll find a predisposition to clotting in a certain percentage of the population triggered by this vaccine. Right now, I'm not saying we should exclude those with clotting disorders from vaccine from Moderna and Pfizer. Should we exclude those with immune disorders? No. So this is just a discussion of the disease state. So my observations over time have been that I have a number of patients now that are coming in with COVID disease, sick, that are less than 7 days post-vaccination, which means don't let your guard down. Even if you've been vaccinated, you must remain vigilant on the masks, distancing, being cautious. We've not seen post-vaccine Guillain-Barré syndrome, which remember the swine flu vaccine back in the 70s. There's a lot of post-vaccination sort of neurologic disease that occurred. People couldn't function, they were hospitalized. We're not seeing a lot of those. I haven't seen one, by the way. So that's really reassuring. I would expect to see breakthroughs. This Seattle, and then I think there was Chicago discussion of, oh my goodness, you know, these people have been vaccinated, they're going to the hospital. Well, that's the 5% that aren't protected as well as you'd like with vaccine for whatever reason. Maybe their immune system wasn't strong enough. Maybe their vaccine didn't take, or you know, they had a high viral load. I think viral load's important. The vaccine rollout is going extremely well. There have been some comments about sites closing like Georgia. Well, this was for what I think were vasovagal response, like, oh, I fainted. I'm not sure if any of you have had this. I fainted after giving blood once. It was really embarrassing, but it's a natural event that occurs. It's a vasovagal response. It's sort of a pain equivalent. You're going to see that happen, frankly. Nothing's benign. I think we have to wait and see what happens with the clotting issues. And I think now is the time to vaccinate the population with the B117 before the South African and Brazilian variants start to take hold. And I think that's very important. And I would encourage everyone listening to think about that or watching to think about that. But I think, you know, talk to your health provider, talk to your friends and colleagues. So you are fully vaccinated when you are 2 weeks after your second dose of the Moderna Pfizer or 2 weeks after the single dose J&J. You're not fully protected, although I think there's some partial protection. If you have been fully vaccinated, you don't have to wear a mask when you're home or around other fully vaccinated people. I had a friend who he took his mask off for the first time and he grew a beard. I didn't have the heart to tell him I didn't like it, but it was, you know, it was like, oh, nice beard, you know, and sorry, if you're listening, I apologize, but I know you're not. So you don't have to wear a mask inside or at home when you don't have to wear a mask inside a home and visiting unvaccinated people from one other household. So this loosens things up. So even if they're not vaccinated, you're safe. And you don't have to quarantine if you've been in contact with someone with COVID, if you've been vaccinated. So these are all one step beyond full distancing, full masking, full quarantining. But it doesn't say stop doing it. If you're in a public place, you remain vigilant.
One caveat to that, I think, Doctor, is if the unvaccinated people are high risk, that you need to still wear the masks and all that, right?
Yeah, I think I'm glad you said that because you're right. I went through that pretty quickly. I think if you're with someone who's unvaccinated with the comorbid conditions you worry about, immune disease, diabetes, hypertension, those are a higher risk for disease being prominent. I appreciate that. And you're right. Yes. So fully vaccinated people should still wear face masks and social distance in public and when indoor settings, wear face coverings when they're around visiting unvaccinated people that are of high risk, still avoid large gatherings and watch out for symptoms and still get tested. Getting vaccinated does not change testing or how well the test works. And we do know that the COVID vaccine is effective in preventing disease, preventing spread of disease, and preventing severe disease. I think those are all really important issues. We still don't know how effective they are against the variants. I think we'll see some good outcomes with the B.1.1.7. And we also don't know how well the COVID vaccinated will spread disease. I think increasingly we're seeing very little spread from that population because the load is so low. So look forward to more data. With that, I'm going to stop and I'm going to turn it back over to Chief Justice to share, I think, a discussion of or a video of some of your colleagues that have gone through this process.
We're going to do that. I have a couple questions that we've gotten to see if we can get your reaction to it. What's the latest research on how long your protection lasts for when you get a vaccine?
I think with natural disease, we're now thinking it's at least 6 months. And with vaccination, it's clearly out to 6 months, 180 days. And my suspicion is we'll move to a year at some point in time once that vaccine, we're out a year from vaccinated patients and those study populations are out a year. I think we'll probably move to an annual vaccination technique where the current circulating variants are looked for and identified. So I would not be surprised to see an annual booster in that setting. But I think we're now at 6 months and probably every 3 months will go out.
Okay. And if you've had COVID, do you need to wait to get a vaccine?
I think the current comments are that if you have COVID, I've had people that have gotten vaccinated, gotten COVID. The current guidelines are to wait 2 weeks post-disease to get your next vaccine, keeping in mind that you can go out up to 6 weeks with your second dose of Moderna, Pfizer, and still be adequately protected. So it's 2 weeks post-COVID, you can then talk about getting vaccinated, and you should get vaccinated.
Okay. And among the 3 vaccines that we have right now, we know J&J is paused for the time being, but it may come back relatively quickly. All 3 of these vaccines are highly effective at keeping you out of the hospital and keeping you from dying. Is that right?
Yes. I mean, the data shows that 5% are still at risk, but those 5% are rarely hospitalized and rarely proceed to ICU care. And that's actually a really important distinction. So they remain very efficacious, they work, and I think they're very, very safe, frankly, but
Okay.
that's my own bias.
And when you said it's important to keep getting tested, does it matter what kind of test you get if you've been vaccinated? In other words, does an antigen test show false positives if you've been vaccinated? How does all that work?
No, the antigen test will never be false positive for a vaccinated person because the vaccine, unlike some vaccines in the past, we would give live attenuated or vaccines that were similar to the virus. You might get a false positive testing. There's no scientific way that this vaccine can give you a false positive COVID test. So the testing remains as it was before, nasopharyngeal swab, oral testing with a PCR test is the gold standard.
Okay. I think you've already talked about why you get the injection in the arm. The reason is because you have access to that muscle there, which is what starts the immune process. Is that right?
Yes, your smooth muscle of the arm is, in fact, for many vaccines, hepatitis included and recent vaccines, the data shows you get much better immune response with using your arm bicep than using your gluteus, which is your bottom, which was traditional site of vaccination. Plus, it's easier.
Okay. Does it really matter where in your arm they stick you?
Upper arm, right? No, I don't know the answer to that.
Okay.
I think upper arm, yeah.
Okay. And as I said earlier, I think as far as the age issue is for the Moderna vaccine, it's only authorized for 18 and above. The Pfizer vaccine is 16 and above. And do you know what J&J is?
I don't.
Okay, I don't either. That's something that we could find the answer to.
We have 2 weeks to find out because it's on hold for a couple of weeks.
That's right. Okay. And as you said, I think it may be that the vaccine for this will become an annual event. Isn't that right? Just like the flu shot, because you can, especially with the mRNA technology, you can adjust for the variants that have potential worse outcomes, right?
I think we'll see annually. I think certainly for healthcare providers, we'll see an annual booster. And I don't know about essential workers or other populations.
Okay. And how about going back to work? When some of our judicial branch employees are coming back into the courthouses that are not there now, it's still going to be important to wear masks and social distance and wash your hands and all that. Isn't that right?
Equally important, or more so, with the B117. I think that's the biggest concern now, is as the variants show higher viral loads and increasing ability to spread, even in a vaccinated population, you might have more virus in the area than you like. So the answer is yes, clearly, yes.
Okay, thank you.
Yeah.
All right, and we have our non-medical experts saying J&J is 18 years old, so we'll confirm that, but that seems to be the thinking. Okay, so what we're going to do now is we're going to play just a very short 3 or 4 minute clip, video clip, to talk about people's experiences with vaccine in the judicial branch. So Gail, if you'll play that video, that'd be great.
My arm was a little sore, just like after I got a tetanus shot. I wasn't 100% after my second shot the next day, but then quickly back to normal. Didn't miss any work, didn't miss any activities.
I had no side effects with the first shot, minimal reaction with the second shot. That included a sore arm, fatigue, chills, and it lasted about 8 hours.
That first day when I received it, I had a few side effects, a little bit of soreness at the injection site, and I felt some aches and pains the next day. But by 36 after the injection, I felt perfectly fine, and I have felt fine ever since.
The pharmacy wasn't busy at all, and there was one person ahead of me. It did sting when it went in. I mean, I get that from like a B12 shot or a flu shot, and I didn't have any side effects other than some swelling, a little bit of injection site soreness.
It was very efficient. There was very little waiting. Everybody was friendly and helped with the explanation of the side effects. I only had like a headache afterward. It goes away. Just know that it does go away.
It was very organized and it went very quickly. And I was one of the folks that had no side effects.
My husband and I went together to take the shot, and he didn't have any symptoms. Overall, the experience was pleasant and the side effects were mild. I had a slight headache. I had chills at night, and then just overall tiredness.
I'm very grateful to have it because today I am headed out to LA to see my daughter, and I'm not worried about flying on an airplane. I'm not worried about being around her. I can hug and kiss on her as much as I want, and that's what I want to be able to do. It gives us the chance to have normalcy back in our lives.
In my tight, close-knit family, I've had over 10 relatives test positive for COVID, some with severe symptoms that required them to be in the hospital for multiple weeks. The vaccines are our best chance to get back to normal.
It was very important to me to receive the vaccine to prevent disease in myself, but also to protect others in the community. And I think it's also important to remember that this vaccine has been proven to reduce severe disease and death. For every person that gets the vaccine, that brings us one step closer to herd immunity.
I felt it was important because I have friends who contracted the virus. One friend was in bed for 10 days, she said, and several other friends who have had it. I have one friend who actually said she's been in and out of the hospital for the last 3 weeks. Her family's taking care of her. She's having problems breathing, and that's really scary, not being able to breathe. I was able to go to my family for Easter, which made me very happy. I hadn't seen them in over a year. I started crying when I saw my sister and my aunts and uncles and my cousins. That was really great. They had all had their vaccinations, or at least their first one. So I got to see my family, which was awesome.
I got the vaccine because I work with the public. I interact with them on a daily basis, and because my parents are in the at-risk category, and to better protect myself and be more comfortable in my position so that I know I'm protected.
I felt compelled to get that vaccination so that I know when we invite people back into our courthouses, not only are they safe, I'm safe, and I'm not a possible person that's spreading the COVID-19, which has just shuttered so many state offices, including the Delaware courts. And I'm very glad I did it. I feel that I'm more safe, and the people that are coming back into our courthouses are safe.
I feel it's important to do my part to end this pandemic. We're all hoping that it will end soon. And I work directly with the public, and I believe that it's important to be protected and to protect others. I do also have relatives who are elderly, and I'm in contact with individuals who are in the high-risk group. So anything that I can do to not pass on the virus.
All right, thank you very much. And Dr. Bacon, as always, it's been a delight to spend some time with you and answer all these important questions. We'll do it again in May, hopefully, and we can't thank you enough again for the time that you've dedicated to the judiciary, helping us with our reopening plans and guiding us through this pandemic. It's something that we really appreciate very much.
Well, thank you for saying that. You're welcome. But I'm honored to have a chance to help. And frankly, what you all do for the state and beyond is it's very important. And I appreciate the efforts you put forth in all this. I think you're doing a really good job getting people back into the arena safely and cautiously. And I think you're doing quite well with all this. Thank you.
Thank you, Doctor. And that ends our town hall. Thank you. One last point I will make, and that is if you want to get the vaccine and have not had the opportunity to get it yet, please talk to your court administrator or your supervisor. Elmer Setting, who you saw in the video, is in charge of vaccinations. We will figure out how to get you vaccinated if you have not gotten a vaccination yet. So please reach out to us. We're here to help arrange you to get a vaccination. Don't be shy. Everyone really needs to get vaccinated. So thank you again, Dr. Bacon, and thank you everyone for attending.